I am Professor Aziz-ur-Rehman, and today we are going to discuss this condition called cardiac failure. Some would call it heart failure, others would call it decompensated heart. Some say that just saying cardiac failure is perhaps not right because many times the heart is slightly compromised, not exactly completely failed. So I think whatever terminology you use, we are going to discuss it in detail today. And it could be a serious condition with a relatively poor prognosis. And luckily, we have a number of treatment options where we can help the patient and make his life easy and also prolong life. Let's take up this matter, and this is actually a series of 2 or 3 lectures. In the first one, we will discuss the etiology, the pathophysiology, and the diagnosis. And in the second lecture, we will discuss the management and the prognosis. So let's take up with the first one. Uh, it is always difficult to define any condition because there is actual in real world any disease does not have clear boundaries. So, but when we have to define them, we have to give clear boundaries. So I think it is always difficult, but this is the best definition I could come up with. When cardiac output is unable to meet body's hemodynamic requirement without hypovolemia. I mean, if there is hypovolemia, for example, somebody had uh, blood loss, somebody had severe vomiting, diarrhea, or any other fluid loss, then of course cardiac output will be reduced even if the heart is normal. But cardiac failure is said to be present when there is no hypovolemia. Still, because of some intrinsic problem in the heart, it is unable to produce sufficient cardiac output, which is actually required for that given physiological state. So this is the definition, and of course there would be multiple conditions leading to heart failure. Now, I think this is a very nice picture and showing the normal circulation, left heart pumping blood into the systemic circulation, and then it goes to the brain as well as the body, goes through various beds of circulation, come back to the right side, and then goes to the circulation in the pulmonary circulation, gets oxygenated, and come back to the heart, left heart. Heart failure can be classified from various perspectives. Now, advantage of this concept is that you actually consider several aspects, and that actually give you a better understanding of the disease and help you to plan the treatment better also. Now, let's see what are those. First of all, we could call left heart failure, right heart failure, or biventricular failure. Of course, ultimately, I believe it would be biventricular failure, but there may be a condition. Most heart failures, they relate to left heart failure. So suppose there is a condition where left ventricle has failed, and of course, ultimately, it would result in to right heart failure also. But there may be a situation where, like for example, acute myocardial infarction, left heart has failed, whereas right is okay. Or similarly, in pulmonary embolism, right heart could fail and left may be okay. In congestive cardiac failure, in cardiomyopathy, typically both ventricles will fail. So this is one classification, and the other one is forward versus backward failure. Now, forward refers to reduced cardiac output. If heart is unable to produce sufficient output to meet body's requirement, that would be forward failure. But if blood, the heart is, in case of left ventricle, if it is unable to remove blood from the pulmonary circulation and resulting into pulmonary congestion and pulmonary edema, that would be backward failure. So again, there would be forward failure as well as backward failure both together, but there could be one component predominant that could actually help in giving the right treatment. For example, somebody is having a forward failure, and the extreme of that would be called cardiogenic shock. There would be specific medicines which will be used. If somebody has backward failure, that condition is called pulmonary edema. Again, there are some specific agents which are used, or at least some agents which are preferably used in that situation. Then low or high cardiac output failure. You could argue that we define heart failure where there is reduced cardiac output. The cardiac output is less than what is the requirement of the body in that situation. But how could then you can have a cardiac output which is increased? So in this case, actually, cardiac output is high, but not high enough to meet body's requirement. Imagine somebody with hyperthyroidism, somebody with pregnancy, somebody with AV fistula. In that patient, the cardiac output would be higher than normal, despite the fact that heart is failing, but less than what was actually required under those circumstances. So this is the concept of high versus low cardiac output failure. Unless specified, most cardiac failures would be a low cardiac output failure. Then acute or chronic. Of course, anything which occurs acutely suddenly would be more devastating, will be more symptomatic, because it would not allow body's compensatory mechanism to act fully, and then the chronic heart failure of the same condition would lead on to become chronic. Chronic heart failure would be definitely better tolerated. Acute heart failure, like for example occurring after myocardial infarction, would be very symptomatic. So accordingly we assign the prognosis. Then systolic versus diastolic. The traditional concept about heart failure is that the heart does not contract properly, and if it would result in reduced stroke volume. One of the measures of stroke volume is ejection fraction. So when we measure with echo, it would be expected that ejection fraction is reduced. Then diastolic failure means that heart can pump all right, or pumping is not that much affected, but during diastole, heart does not fill properly because of increased stiffness. So this would be referred to as diastolic heart failure. This can occur in many conditions: hypertrophy, patient with ischemic heart disease, patient with restrictive cardiomyopathies, patient with pericarditis. So these patients can have diastolic heart failure. Many would have combination. According to one estimate, diastolic heart failure may be present in up to about 40 to 50% of the cases of heart failure. Then lastly, we have this new terminology. It is actually the translation of this one, but these days we refer to heart failure as heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So with the reduced ejection fraction means ejection fraction less than 40, and preserved mean more than 40. So I think these are different classifications of the same problem, highlighting various aspects. So that should enable you to understand this disease process fully. So let's move on to the next slide. The etiology actually is a long range. We have discussed congenital heart disease, valvular heart diseases, hypertension, ischemic heart diseases, rheumatic heart diseases in the previous lectures. Actually, all can lead to heart failure. Ischemic heart disease, of course, hypertension, if it is uncontrolled, chronic. Valvular heart disease, particularly those valvular heart diseases which put extra volume or pressure overload to the left ventricle. Congenital heart diseases, cardiomyopathies is a group of disorders where there is the primary disease of the muscle of the heart, and that could cause heart failure. And then of course there's some miscellaneous causes. So all heart diseases if they are advanced enough, can actually lead to heart failure. Now, this way, I think I'm going to explain some of the neurohormonal changes in heart failure and the pathophysiology of heart failure. So these are various steps: primary abnormality and compensatory neurohormonal changes, compensatory hemodynamic changes, and then ultimately decompensation, resulting in some clinical manifestation and also in some laboratory manifestations. So I will show you all these one by one to let you understand it better. So first problem is decreased contractility of the cardiac muscle. Examples are ischemic heart disease, myocardial infarction, cardiomyopathy, or increased pressure or volume load. So pressure or volume overload. Pressure overload is a situation where heart has to contract against a resistance. In case of left ventricle aortic stenosis, hypertension would cause pressure overload. Volume overload is a condition where ventricle fills more than the usual. It receives more venous return, maybe because of some shunting or maybe because of regurgitation. The ventricle receives more blood, so it has to pump more and ultimately it fails. Examples of volume overload in case of left ventricle would be aortic regurgitation, mitral regurgitation, ventricular septal defect. In all these conditions, left ventricle is receiving more than the usual amount of venous return, and that could put the heart under pressure. Of course, there will be compensating mechanism, but ultimately all compensating mechanisms, they fail and a clinical syndrome of heart failure may develop. And what are those compensatory changes? There would be activation of RAS. RAS is, as you all know, renin, angiotensin, aldosterone system. So this is a very complex system which gets activated. The aim is RAS actually senses that there is reduced cardiac output because of perhaps a deficiency of sodium and water, and it tries to retain sodium and water as an attempt to compensate for the heart failure. At the same time, there would be activation of central sympathetic nervous system. From the brain, the sympathetic nervous system would be stimulated, and that would also result in certain changes, certain vasoconstriction, certain vasodilatation, increased cardiac contraction. So all these things are actually nature's attempt to compensate for the problem which is there. So these are neurohormonal changes. Neurohormonal changes translates into some hemodynamic changes, and they actually help. Vasoconstriction, RAS activation would result in the formation of angiotensin 2, which is a vasoconstrictor. Attempt is to raise the blood pressure, and then RAS system will also activate the aldosterone, and that would help to retain sodium and water. At the same time, sympathetic nervous system would also cause vasoconstriction in certain beds like in skin and in muscle area and splanchnic area, and it would preferentially cause vasodilatation in brain and in heart coronary vessels. So this is actually the hemodynamic compensation for failing heart. Then ultimately, because if the primary cause is not corrected or is increasing, then ultimately heart will decompensate, and that would result in dyspnea. Various types of dyspnea we will discuss in symptoms. It would cause cardiomegaly. It would cause engorgement of neck veins if right heart fails, and it would also cause hepatomegaly, and it may also result in edema in the peripheries. So all these are actually clinical signs of advanced decompensated heart failure. Now, these are some of the neurohormonal activation in heart failure. Norepinephrine is elevated. Plasma renin activity is increased. Plasma renin activity is increased. Vasopressin, which is also called antidiuretic hormone, will also be increased. Atrial natriuretic peptide may be increased, will also be increased, and endothelin will also be increased. All these are actually not measured to make a diagnosis except this atrial natriuretic peptide. Actually, NT-proBNP is one of the types of atrial natriuretic peptide which is measured to make a diagnosis in certainly not in all cases, but in relatively difficult cases where you cannot make a diagnosis based on conventional tests. It will become more popular and will perhaps become a regular test, but at the moment we are doing it only in some selected cases. So these are neurohormonal changes in heart failure. Nature increased these levels to compensate for the heart failure, but we can use some of them for the diagnosis of heart failure also. This is the remodeling. Remodeling, if this is the normal heart, you can see a relatively small cavity. You can see the papillary muscles and thick uh, uh, wall. This is perhaps early hypertrophy, concentric hypertrophy, because this wall definitely looks thicker than normal. And when it fails, ultimately it dilates. The thickness actually reduced when it's stretched out. The thickness is reduced, but the cavity size is increased. And this is a model of dilated cardiomyopathy. Now, diagnosis is sometimes very obvious, but sometimes we have to go through this process. And I think it is always good to go methodically. First of all, we will take up the symptoms. Uh, we 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 uh, we go this way. So first of all, symptoms may be very suggestive. Immediately after listening to the patient, we will examine the patient. So there are certain signs which are very helpful. And then traditionally, the first investigation of choice is X-ray, and X-ray is readily available and I think still very useful test. Although 2D echo or M-mode echo or just simply echocardiography has replaced many other tests because it gives you very detailed information. In some cases, where echo does not show classical changes or echo is not available, then NT-proBNP may be used. NT-proBNP will be actually useful to differentiate between heart failure and other causes of dyspnea. So I think that is the importance. So this is how we proceed in patient with heart failure, diagnosis wise. We are going to take up all these topics one by one and discuss them in some more detail. Then finally, there will be nocturia. These patients, they tend to pass urine at night. There are other causes of nocturia, but in this context, nocturia would also suggest the possibility of heart failure. Like symptoms, there are some very characteristic signs also. I think if you pick them up, they can be very helpful in the diagnosis of cardiac failure. Uh, S3 and S4 gallop can be present, and there may be a faint systolic murmur. S3 gallop means that the left ventricular filling is increased, and S4 gallop means that atrial contraction has become more forceful. Both of them actually indicate that left ventricular and diastolic volume is increased. Murmur may be occasionally present, indicating the primary etiology, or may also indicate a regurgitated murmur resulting from heart failure. Then bilateral basal crepitation. I think this is the finding. In every patient with dyspnea, you must examine the chest very carefully. And if you find bilateral basal crepitation, which are fine in nature, they should very strongly suggest that this diagnosis. If the crepitations are widespread and are coarse, not specifically localized to the bases, I think then you should consider an alternate diagnosis, preferably from the lung diseases. But in heart failure, in the proper perspective, in the proper setting, fine crepitation bilaterally started from the bases, it could go up to the mid zones, and in cases of pulmonary edema, even up to the apices, but they always start from the lower zone and they are, I think, fine in nature. That means they are best heard in the inspiration. Then we have engorged neck veins. Please remember, this will be seen only in those who have gone into congestive cardiac failure or there is right heart failure. And there is a specific method of examining neck veins. You must follow that method, otherwise you might reach a wrong conclusion. And the right method is that patient must be put at a 45 angle, and only then you should see if the neck veins are visible above this supraclavicular fossa, and you should measure the actual height of those neck veins. Then congestive hepatomegaly. Of course, if things are going worse and worse, then there could be congestive hepatomegaly. Liver would be enlarged and somewhat tender, and ultimately ascites and dependent edema. Dependent edema typically refers to the ankle edema, but if somebody is dependent, is bedridden, in that case dependent edema would refer to the sacral edema and also the scrotal edema. So these are some of the signs. If I have to pick up one, would be I think resting tachycardia with some gallop and very, very important bilateral basal crepitations. So signs are very important. These signs are primarily those of left ventricular failure, but the engorged neck veins, congestive hepatomegaly, ascites, and dependent edema are signs of right heart failure or biventricular failure. This is, for example, an example. You can see this patient is at 45 and you can see neck vein is visibly engorged. It is so much engorged that you can't see the upper border. It has gone beyond the angle of jaw. So the central venous pressure must be very, very high. This is another patient showing pedal edema, which is pitting in nature. And obviously, you know the technique. You press your thumb against patient's ankle and against a bone and keep it pressed for a few seconds. Then when you lift your hand and if you see that there's the pit formed which stays there for some minutes, then that is called pitting edema. This is actually seen in many other conditions, but in this setting, you would consider it as you would consider it as a part of right heart failure. Now, investigations. There are many investigations which are useful. First of all, I think X-ray chest. As I said, X-ray chest is very, very useful. One advantage of X-ray chest is that it is readily available. Another advantage of X-ray chest is that many times we actually are not exactly able to differentiate between a pulmonary condition and a cardiac condition causing dyspnea. These are two important causes of dyspnea, and if patient presents with dyspnea, you have to actually differentiate and you have to first make sure that this is cardiac or respiratory. So X-ray chest is a great tool to tell you if it is cardiac or respiratory. And in cases of cardiac dyspnea, you would expect some cardiomegaly and maybe some pulmonary edema. Then echocardiography is extremely useful. Usually available on the bedside, or patient will have to be taken to the next door room where this echocardiography is available. Non-invasive tests, even if patient is very sick, this test can be done, and it gives you a lot of information about heart failure. In fact, this is the diagnosis. I think after echocardiography, there is usually no doubt about the diagnosis. Then this anti-pro-BNP. I told you that in heart failure, many neuroendocrine, neurohormonal changes occur, and they are actually compensatory. They try to help heart failure in a way, but they can be used for the diagnosis also. This anti-pro-BNP is a kind of atrial natriuretic peptide which is produced by the heart, and it has got diuretic effect, and it also has got a vasodilator action. Both actually help. So and this anti-pro-BNP is not destroyed by neprilysin. Neprilysin destroys other types of ANPs, but this one is not destroyed. So this can be used for the purpose of diagnosis. If in somebody's who is presented with dyspnea and anti-pro-BNP is elevated, that would suggest the diagnosis of heart failure. Now, this is X-ray chest. You can see, I think even without measuring, you can see that there is somewhat cardiomegaly. May not be gross, but there is cardiomegaly. And you can see, I think, pulmonary edema. Definitely, there is this infiltrates. Pulmonary edema is typically bilateral, and it produces a bat wing type of opacity. In this case, it is predominantly on the right side, and that can occur actually depending upon patient's posture at the time of X-ray chest and maybe few hours preceding that. So I think in this case, you can see this fluffy bat wing type of infiltrate indicating pulmonary edema, and I'm not sure if there is any pleural effusion. There may be small, but pleural effusion may also be present in some cases. Now, this is another case, and this has got massive cardiomegaly, and I think one could consider the possibility of pericardial effusion also, but this is actually a case of dilated cardiomyopathy. Patients with dilated cardiomyopathy also have massive heart, and the picture may be very much similar to that of pericardial effusion, because even in cardiomyopathy, lung field may be relatively clear. That is a typical feature of pericardial effusion, but that can also be seen in dilated cardiomyopathy. Now, this is how we measure it. I mean, this was actually described in some other lecture also. But if you want to measure the size of the heart, when would you say that there is cardiomegaly? When the maximum transverse diameter of the heart, which is represented by this thick bar, you take the most convex part of the right border and the most convex part of the left border, and you draw a line and you measure it. Now this should be less than the half of maximum internal thoracic diameter. This line should be drawn on the inner side of the costal structure, and again inner side of the ribs, and the distance between two is maximum internal thoracic diameter, and this is the midline. So this should have stopped behind this. In this case, there is obvious cardiomegaly. So I think, but these things, the cardiomegaly would take some time to develop. It may not be seen in acute heart failure, but in chronic heart failure, you will be able to see it. Now, as I said, echocardiography is extremely useful, and this is 2D echocardiography, and this is M mode echocardiography. Now, I think I will not be able to go into the details. 2D is, of course, two-dimensional. You can see the structure in two dimensions, and this is actually one dimension. This is the septum, and this is the no. This is yeah. This is interventricular septum, and this is left ventricular posterior wall. And you can see with each systole, the septum and the left ventricular posterior wall both moves inward. So this part would represent systole and this part would represent diastole. I'm going to show you it in some more detail. Suppose now this is actually a cursor. This is the imaginary line through which the ultrasound waves are passing and acquiring the image which is shown here. Now, with each systole, these two will move inward, and diastole, they will move away from each other. Now, here, for example, this is, what do you think, is systolic phase or diastolic phase? This, of course, is diastole. Septum has moved forward and the left ventricular posterior wall has moved backward. That means it is diastole. The left ventricle has dilated. So this is that diastole, and then this point is systole. Now if you can measure this dimension, then using certain formulae you can actually measure the volume during diastole and the systole, and that is shown here. So if you measure left ventricular and diastolic volume, which will be calculated from this measurement, and left ventricular and systolic volume, which would be measured from this distance, and then the difference would be, of course, the stroke volume. So this actually number represents the stroke volume, and this divided by left ventricular and diastolic volume multiplied by 100 would give you the ejection fraction. Ejection fraction is actually the percentage of the blood which is ejected from the left ventricle into the aorta with each systole. Now, assuming that the blood is only going to the aorta, this figure would give you the exact left ventricular status. If somebody has mitral regurgitation, this might not give you the true picture because some of this ejected blood is actually going back to the left atrium. And if patient has what we call segmental wall motion abnormality, the different parts of the heart, they have different level of contractibility, then again this might not give you the true picture. And then there is a type of heart failure where ejection fraction may be normal or may not be reduced to that extent. So these are some of the limitations, but overall echocardiography and ejection fraction gives us very, very useful information. Now this is actually another video. I think it's a video. Let me see if I can play it. Yeah, this is normal heart and this is the disease heart. You can see that contraction here and you can see the Doppler factor, and this is much sluggish, dilated. All chambers are dilated and moving slowly. You can even see the movement of the cusps are so slow. So I think this should be even visually obvious, but when you measure the exact things, then the diagnosis become very, very easy. Now, coming to the diagnosis, actually we have already discussed this process, but just to recapitulate, we start with symptoms and predisposing factor. Symptoms of dyspnea, which may be simple exertional dyspnea or orthopnea or paroxysmal nocturnal dyspnea, nocturia. And then predisposing factor means that we already know, if we already know that this is a case of ischemic heart disease or this is a case of dilated cardiomyopathy, then of course the weightage of these symptoms will be increased. Then signs. In signs, I told you two important signs. One is the presence of gallop, tachycardia, and the second one is presence of bilateral basal crepitations. And then XHS. In XHS, the cardinal thing you would be looking for would be cardiomegaly and also the presence of pulmonary infiltrate. In its classical form, there will be pulmonary edema, but in less classical case, there may be pulmonary infiltrates, may be patchy, usually bilateral. There may be pleural effusion also. Pleural effusion in heart failure tends to be bilateral, but there would be a time when it would be seen only on the right side, because somehow this fluid tends to accumulate on the right side before it starts accumulating on the left. So there may be a time when the effusion is small, it will be obvious only on the right side. Echocardiography, is very useful test, and it will tell you the exact status. It will give you the exact ejection fraction, and if there is any segmental wall motion abnormality, if there is additional clot, if there is other problem, that will also be seen on echo, and you can very accurately follow up the patient on echocardiography. Suppose at the time of diagnosis ejection fraction was 30, and with treatment and then it has improved to 40, 45, that means things are getting better. Then NT-proBNP is the blood test for the heart failure. I think this was discussed in detail earlier, so I'm not going to go do that again. So these are the tests. I think in clinical practice, you may be able to show at any level. I think echocardiography must be done in all patients because that is extremely useful. So that was it. I think we have discussed the etiology of heart failure. We have discussed various types of heart failure. We have discussed clinical features of heart failure, symptoms and signs, and we have discussed the pathophysiology of heart failure, the certain neurohormonal changes, and then we have discussed the diagnosis of heart failure. So I think we have done this much in this lecture, and we will follow it up with another lecture which will focus on the treatment of hypertension. Of course, knowing the disease is not good enough unless you are able to treat it also. So please join me in my next lecture on treatment of heart failure, treatment of cardiac failure. This is Professor Aziz-ur-Rehman from Medurstand. Thank you very much.